Today's video, we're going over 12 keys to successful post-op ACL reconstruction rehabilitation. What's going on, guys? My name is Dan Pope. We also have Kevin Coughlin. We are physical therapists, and like always, we delve into the literature to find all the answers you need as a physical therapist. We take the best information, we throw out the garbage, give you our clinical experience, and we try to make you learn a little bit and get a little bit smarter. How you doing today, Kevin?
Dan, I'm doing well. This was a fun one to create. I think it was challenging to distill all this into 12 keys, but I think that key number 12 is the most important, and that will be the best one to finish with and really send people out of here knowing what to do with their patients post-op.
Got to stick around to the end. Number 12 is a big one.
All right. So there are so many ways I felt like we could have taken this episode and how to distill the information out there. But I think these two articles included a lot of good information. And although a bunch of other articles are included, I think these did a good job of covering the basics and everything that I think we should be thinking about. And I'm sure there's things I've left out. I tried to be pretty comprehensive with this. So the two articles, the first one, if you're looking at the slides on the top left, was published in Sports Health in 2021. And this is from Lynn Snyder-Mackler and colleagues. So that research group that does a great job and puts out a lot of good quality information, I think. ACL reconstruction rehabilitation, clinical data, biological healing, and criterion-based milestones to inform a return to sport guideline. So that was one study that I included here. And then the other one is from Kevin Wilk, great researcher, has put on a lot of good stuff. And this was in Clinical Sports Medicine in 2017. Rehabilitation principles of the ACL reconstructed knee, 12 steps for successful progression and return to play. So I landed on 12 keys. He has the 12 steps. I did group some of his steps together and included a couple other things, but that's kind of where I got the idea. I think this paper was really good. And even though it's a few years old at this point, I think it's worth going back and looking at for folks because he does a great job with these kind of clinical commentary papers. So I think it's worth looking at for people and checking out.
I'm excited to see the 12 steps.
Okay, so key number one, we talked about this in a previous episode, and I think it's worth going back and just checking that out. But I think the first key is successful pre-op rehab. If you have the time with the patient, if you have the ability to train them pre-op, we know it leads to better outcomes post-op from some of the studies that we talked about last episode. So we want to achieve a quiet knee. That's kind of the first big thing physically. We want to get that. So what does that mean? You see that in the research a lot is first we want to reduce swelling to a 0 or trace. And that's kind of what I was talking about on the previous episode, where if we're doing the sweep test, which is a good test to look at swelling, 0 means there's nothing going on. We're not seeing anything. With trace, you do your little sweep and then you provide a down sweep on the lateral knee. And then back on the medial side, you may see just a tiny bit of swelling. We kind of want to get our patients to that point. We want to reduce pain as much as possible so they can train before surgery. We want to get full range of motion compared to the contralateral side. We want to try to normalize gait. And we want to test these people. We want to know before surgery, what is their strength? We know they're going to lose strength on both the good side and the bad side before surgery. So we want to know what their baseline is. And ideally, we want to have symmetrical quad strength, or at least greater than or equal to 80% on the painful side versus the non-painful side. So definitely want to look at those things. And then you can go back and listen to the previous episode about all the other things we're including in pre-op. We also want to consider psychological preparedness. So we explain to the patient what the post-op kind of rehab looks like. What are your general time-based, criteria-based progressions? Like, generally folks will start some light plyometric training, maybe at month 3. They might return to run around month 4. They might return to sport somewhere between months 9 and months 12. We want to make sure the person understands this and they know that just because they have a friend that got back at 6 months, that's not the norm. Understanding this is a huge thing. I think these patients, they don't get to spend a ton of time with their surgeon. So when they come in to see us before PT, we can really lay out the roadmap for them of what this is going to look like. This is a big barrier to their life. It's going to change the way they do things. And we want to make sure we give them good information before, so none of this is a surprise. They can kind of plan out the next 9 to 12 months of their life and have some idea of what's coming. And I think they find that reassuring, and they really appreciate when we take time to talk about those things. So I think that's a big part of this first key.
Hey there. Sorry to interrupt, but I've got something cool. It's an evidence-based exercise selection cheat sheet after ACL reconstruction. Sometimes it's a little bit scary working with patients after ACL reconstruction. Obviously, you don't want to hurt them, and the exercises that we choose matter. So I created a cheat sheet to help you out. It goes over which movements have the most strain on the ACL graft and how to dose those exercises from low to high. We use the evidence to guide us so you can make the right decision for your patient after ACL reconstruction. We'll also tackle that age-old question of whether or not you should be using open kinetic chain knee extensions with your patients early on after ACL reconstruction. This cheat sheet is 100% free. I'll leave a link in the show notes in the description below. Go ahead and click on that and get to learning. Now, back to your video. Yeah. Yeah, I totally agree with you. I think setting patient expectations is really important. And I think the ones that are particularly important are talking about, let's say, pain, swelling, and just knowing that it goes up and down a lot. One of the biggest things I see is that patients have some extra pain. They're like, oh, retore my ACL. And you're like, probably not. Obviously we can go back to the doctor if we're ever concerned about these things, but there's the likelihood that it just goes up and down over the course of time. It's normal. It's natural. It happens. If it's bad enough, yes, we can go see the doctor, but this can be a part of it. If patients have that in the back of their mind, then they get a little bit less freaked out. I've never had an ACL reconstruction, but obviously we've both been injured several times. And the psychological warfare that your body kind of plays on you as you progress along is terrible, right? When you feel more pain, you're like, oh God, what's going on? Why is this hurting? Did I hurt something else? Like, oh, I got to stop everything. Oh man, I'm not gonna be able to get returned back to my, it's ridiculous. So if you set these expectations from the onset and just stick with it and just let patients know, like, yep, that's normal. It's okay. It's all good. I think that actually helps out quite a bit. So good point there. And I'm going to back that up and say that's definitely real.
Okay, so key number 2, your patient has already had surgery. Kind of the first big thing we have to do is reduce the post-op pain and inflammation. We want to try to expedite this process as much as possible so we can start doing the things that we know we need to do to get back to sport, which is ultimately the end goal. So it's well established that pain and swelling reduce quadriceps inhibition, they increase quadriceps inhibition. They reduce quadriceps activation. So we know that. How do we work on pain and how do we work on swelling? So for pain, I think it's okay to tell this person to ice. I know we as a profession, we're kind of getting away from icing a little bit. I think it makes a lot of sense in certain populations. And we'll talk about the relevance and importance of icing for arthrogenic muscle inhibition a little bit later. But icing post-operatively can be very helpful for pain. So I know a lot of the surgeons in our area, some of the local surgeons will send patients home with an ice machine or recommend that they rent an ice machine. And I do think there's utility in that. And patients will report they feel great using their ice machines at home. So don't be afraid to ice these folks. I think it's important and they feel better. Electric stim, TENS, something like that. It might help pain as well. Maybe something to consider. We know passive range of motion is helpful for pain. So some of these folks come in, they've been at home, locked in extension for a few days after surgery, and they come in and they're stiff. Their leg feels pretty crappy. But almost universally, once you start working on their knee a little bit, they tend to feel a lot better, especially if they trust you and they're not fighting you with the passive range of motion. So that can be helpful for pain. For swelling, we know ice can be helpful. Compression might be helpful. So we tend to recommend that after folks are out of their post-op dressing, their incisions are out, or their incisions are healing and stitches are out, maybe get a compression sleeve. Sometimes people feel better with that. They feel like that compression just feels good and helps their pain a little bit. It might play a role in helping swelling as well. I think an important thing to keep in mind is that obviously we all want the person to get off their crutches. We want them to get out of their brace. How long this happens depends on exactly what happened in surgery. If it's just an ACL reconstruction, you tend to get out of your crutches pretty quickly. If it's a allograft, they're probably on crutches a little bit longer. And if there's like a concomitant meniscal injury and they repair it, they're on crutches for a little bit longer. So you definitely want to know what happened in the surgery. But you don't want to rush this either. Even if the timeline says they can come out of their crutches and you can unlock their brace, you want to wait until they're doing better, their pain's better, they're moving better. If we rush this, we kind of create a bad habit and of doing things too quickly. Their knee could get irritated and you could prolong this process. And I think about it as the longer someone's in pain and swollen, the harder it is to get their quad kind of firing again. So definitely something important to tackle early on is reducing pain and inflammation.
Yeah. I'm going to go ahead and just steal your thunder here on purpose. I know, Kevin's going to cover some of this stuff, but just notes on AMI and gait training. I recently made videos. I'll put a link in the show notes, but I go through like all different ways of going through AMI. It's basically things like 10, NMES, biofeedback, so on and so forth. So you can see exactly how we like to do that at Champion, both Kevin and I. Also some gait retraining. So I took some videos of this. Usually I try to make follow-up videos to these long form video podcasts. They're just supplements because we're not going to go through all of our gait training drills with you. Like Kevin's not going to stand up and walk in his room and show all the drills, but I'll do that in another video so you guys can check that out. And the other piece I will say is that patients freaking love ice and they love stim. It makes them feel really good. So I can't tell you, I know that we're like Kevin said, we're kind of moving away from these pain modalities. And I agree with that. I don't think that you should be doing a whole lot of ice and TENS as like a major form of treatment, but early on from a rehab perspective, this can give folks a tremendous amount of relief. And it also reduces that AMI. So there's definitely evidence-based reasons to use these. And patients will tell you like, man, that ice machine saved my life. I love getting on that. I felt amazing, right? So if you're taking that away from patients, you're potentially taking away something that gives them a lot of relief, makes them feel really good, does influence your long-term outcome. Maybe not, right? But the other part is like, it makes them feel amazing in the beginning. Why not recommend that,
Totally. Key number 3 here, restore full range of motion. So you're improving pain, you're improving swelling, try to get motion back. And one of the studies that we have linked in the show notes is showing really good, I believe it's that first paper with Lynn Steiner-Mackler. She has some kind of normative timelines of when people are hitting certain things and regaining full knee extension, regaining full knee flexion. And not every patient is going to fall within those guidelines, but we want to kind of reference that and see if we can kind of match our patient to that. So limited extension is considered the most common complication after ACL reconstruction. So this is something we have to educate our patients about, the importance of working on this. Patients will tend to self-select a little bit of knee flexion because it just feels better. So when they're sitting, hanging out at home, if they pop off their brace, they're going to sit with their knee bent to about 20, 25, 30 degrees. It just feels good. It doesn't feel good to keep it straight. But the problem is the longer you do that, the more often you do that, the worse it feels to move into extension. So kind of hammering this early and often is important. So what things can we do to work on knee extension? From a clinician standpoint, soft tissue to kind of the posterior structures, the hamstring and the calf could be helpful. Low, long duration stretching, I think, is very, very helpful. So in our area, a lot of patients will have a CPM machine that helps them work on flexion after surgery. That depends on the doc and if they prescribe that or not. So it is important that they understand when they're not working on their flexion, they should be sitting with their leg propped up, nothing behind their knee. And if you can accumulate, 4 or 5 bouts of 12 to 15 minutes, something close to an hour per day, it can be really helpful for regaining knee extension. The other thing we'll have patients work on is that when they're in that position, just do some quad sets or stand up and do some terminal knee extensions and just actively get yourself into extension as well. And I think one thing that, we've referenced our coworker Lenny a bunch. One thing he does really well with his patients is when they come into the clinic, before he does anything else, he checks their range of motion, particularly their extension. And that helps him stay on top of it. And it helps his patients understand the importance of it, because if it's the first thing they see the therapist doing, they understand that, hey, this is important. We're talking about extension often. We're asking how they're doing at home, work on their extension. So just make this a priority. You want to get this back quickly. And generally, it can be a little different person to person. We do see some very hypermobile folks with 10 plus degrees of hyperextension. Maybe we don't want all of that back right away, but we do want to get, 5, 6, 7 degrees back pretty quickly. For someone who has more a normal amount of hyperextension, about, say 5 degrees, I think we could get that back in the first month. And that's really what we should be aiming for, is getting back extension within the first month. I think that's what we see in the research. Flexion, conversely, it tends to come back on its own. We don't have to go crazy with flexion. And people tend to feel a little more cranky if you're just pushing their knee into a painful amount of flexion. So don't freak out if it's not coming back. Just monitor it. It will tend to come back. We usually want to shoot for at least 90 degrees by the end of the first week, and then about 10 degrees thereafter. So maybe somewhere about that, 6 to 8 week mark where we're hoping to have full knee flexion at that point. This can vary a little bit person to person. I think it depends on how much scar tissue they lay down or how much swelling they still have in their knee. But we do expect to have back full flexion, I would say, by the end of month 2. So as a general guideline, extension in the first month, flexion by the end of the second month. And there's tons of ways to work on flexion with the patient at home. And I get a little more aggressive with this after the first few weeks when they're not having so much pain at end range flexion. And my favorite exercise is the Dan Pope quad rock back. That's trademarked. That's a great exercise. So I know that I've seen you do this with some of your patients, and I actually think this is really, really helpful, and patients like it. If they're not having pain kneeling on their knee, they get into a quadruped position and they just do a quad rock back. And that's a really good way where they're using some gravity eliminated body weight to work on bending their knee. And patients like it. I think it feels good. They feel like they're in control of how far they're pushing. So that's a good one. One that I didn't include here is just having someone put their foot up on a chair or something and lunging into it. Those ways tend to work. I think I like that better than putting a strap around the leg and just pulling in. But that works as well. That's another way. So there are active ways to work on this. And I think you can start adding that into someone's program. Generally, I think for the quadruped one, they need pain to go away with kneeling. So maybe once their incisions are closed and they feel a little better kneeling on that knee, but it can be really helpful. And then the final thing I think important from a range of motion standpoint is just working on patellar mobility. So just keep an eye on this. I think if someone's going through normal range of motion in PT, I don't tend to see it get scarred down too much. I kind of feel like this is something that works itself out, but you do want to just touch base on that and make sure that you're moving the patella. Someone can work on that at home. Maybe they're doing some mobilization with movement with a quad set and just getting the patella to glide up and down. But I tend not to spend too much time on that. I do feel like that comes back a lot on its own, but something to keep tabs on.
I like that stuff, Kevin. Good synopsis. A couple things. I am filming a video. We go over all of our favorite range of motion exercises and manual therapies too. Soft tissue work, patella mob, so on and so forth. So you can see the infamous quadruped rock back that I like to use. One of the things I will say about range of motion is that, and you had mentioned this, but Lenny just measures knees so much, right? And two things, like you want to make sure that you're making progress, and you want to obviously make sure you're not making progress, but that information is going to dictate how much mobility you need to. Like I don't give my patients low load, long duration stretching from the outset, but if they're stiff into extension, we're having a hard time getting that back, then yeah, I start giving some more of that. It also dictates the frequency of exercises I give, right? And then I want to say that I think it's Lenny's patient, but I think you've worked with him a little bit today or in the past couple weeks as well. He's super stiff into flexion. We're spending a ton of time working on gaining flexion range of motion to the point where that makes up almost the majority of his whole session early on. So if you're having a hard time with a given patient for a specific, flexion or extension, just you can spend more time on it, but you got to measure and kind of understand some expectations. If things are not going well whatsoever, you can just get the doctor back on board. Maybe you are dealing with something like a cyclops lesion or something that you can't change, right, with your hands or stretching, whatever it is. The last piece is that kneeling can be tough for these patients, especially if you have a bone, patellar tendon bone. So if you are doing like a quad rock back, just make sure it's a nice soft surface. You can even offload the patellar tendon a little bit just by having a pad. maybe the pad ends right at like the tibial tuberosity, right? So their kind of knee is hanging off, and they can do some sit backs without putting stress on that area. So just make sure you're not hurting your patients. I don't think that patients are, but those are a few ideas you can use to at least start with your flexing from a kneeling perspective. I feel like a lot of folks don't get back to kneeling, and they're just like, it's not part of the rehab. And I see this in like post-op knee replacements as well. It's almost like kneeling is this forgotten activity that you don't progress towards. So if you do some of these quadruped rock backs, at least you're addressing some of the kneeling that patients feel like they can't do. And, complete anecdote, I just feel that if you put some effort into kneeling with these patients, it may actually improve better than what some of the outcomes maybe show in our literature, mainly kneeling being problematic in bone patellar bone ACL reconstruction patients. I don't really know. Again, it's an anecdote, but that's a thought. Maybe that is real.
Key number 4, individualize and adjust the rehab program based on the status of the knee. So, I think this kind of goes without saying, but kind of one thing Dan had just said that this would fall in this category is, the dosage of mobility that someone's going to work on at home is totally dictated by how they're doing. So just, it's not a one size fits all. Kind of consider how they're doing and how much you need to prescribe a certain thing. But we should consider and change the rehab program based on different graft types, right? So something to keep in mind is that almost all graft types, they're often stronger than the native ligament. I know Dan talked about this in one of our previous episodes. So, that's a cool, important thing to keep in mind. The bone patellar tendon bone plugs tend to set in about 8 weeks. So something to consider for those folks. And then more anterior knee pain is expected. And that's compared to our allografts or our repairs. So, or a hamstring graft, you're going to get more anterior knee pain with the bone patellar tendon bone. And I would say this holds true throughout a lot of the rehab. Now, how much, I think it depends on maybe the surgical technique and how much the individual person kind of scars down. But they do get some anterior knee pain. So you almost feel like as you're rehabbing, you're dealing with the patellar tendinopathy. That's something that you're treating it almost like that. With the hamstring, the tendon to bone healing takes about 12 weeks. So it could take a little bit longer to incorporate than the patellar tendon. With this, we often see surgeons asking us to delay isolated hamstring strengthening. So I'll say this is definitely true in the hamstring grafts I see, is that closed chain or isometric hamstring strengthening, we might be able to start a little bit earlier, but open chain strengthening of the hamstring is often delayed to about 8 weeks. And that period of time is going to affect how much I feel like I have to dose hamstring strength after that. I feel like I really have to bump it up because now we're about 8 weeks behind plus pre-op, whatever we were doing. And the hamstring gets weak. And we know that there are long-term delays in symmetry with hamstring grafts in hamstring strength. So something to keep in mind there. Quad tendon, we also are seeing some anterior knee pain. I think Dan reported on a previous episode. This is less than the patellar tendon. We're seeing a little less anterior knee pain with the quad, but it's something to keep in mind. And anecdotally, that's something we're seeing. And I know you had talked about that challenging case that we have at work right now with the knee flexion. And, he does have a quad tendon graft. So I'd say anecdotally, we're seeing a little more challenge to knee flexion range of motion in that group, which makes sense. When you flex the knee, the quad is lengthening and you might get a little bit of pain with that. We also are seeing that it takes longer for these folks to get quad strength back. So that's a consideration. And you're going to want to individualize your loading program for those folks. So they're doing the appropriate volume and intensity to get that strength back over the course of rehab. Allografts, we have to consider that it's longer to incorporate and mature. We might see some more laxity, and we know that there are higher re-tear rates. So that's going to delay return to sport. Most surgeons that I see their patients recommend allografts wait at least a year to get back to pivoting type sports. So that's a consideration, and that's going to change your rehab. Perhaps you're a little more conservative with your plyometric programming and your agilities and change of direction type exercises with that group. And then just other things we want to consider is, did they have a meniscus injury Was the meniscus debrided or was it repaired? Because that's going to change how we progress and how fast we can progress. Often overlooked, but important, is did they have a bone bruise? I think almost all ACLs tend to have a bone bruise. It's just how severe is that bone bruise, because that impacts how they feel after. You may be scratching your head saying, why is this person so swollen and painful? If you didn't get the chance to see him pre-op, maybe they have a big bone bruise and that's playing a role. So that's going to dictate how you're programming a little bit. Was there an articular cartilage injury or other ligament injury? So the more information you get, the better, and you can individualize each program based on these findings. So try to get all that if you can.
All right, good stuff there, Kevin. Yeah, I agree with you for sure. One thing I will say is that was a study, I just brought it up when you're kind of talking there, 2023, called the Evaluation of Muscle Strength and Graft Laxity with Early Open Kinetic Chain Exercise After ACL Reconstruction for Relly et al. And I think one of the big, debates we've had over the course of time is open kinetic chain exercise safe? And the big consideration is basically open chain knee extension, just because we know that's going to shear the tibia, put some strain in the ACL. Is that safe? In this study, it was on ACL hamstring autograft patients, and they incorporated open kinetic chain knee extension 4 weeks, and then knee flexion at 4 weeks. So this was in hamstring autografts at 4 weeks, and long-term outcomes were better in the group that used open kinetic chain, and there was no like adverse effects. You know what I mean? So if the surgeon allows it, I just don't want physical therapists to feel like they can't do hamstring exercise until week 8. You probably just want to proceed with caution, just because we know that can be pretty stressful on the hamstring. Obviously, pull back if it doesn't feel good. But yeah, it should probably be safe for the majority of folks to start the open chain flexion at 4 weeks for the hamstring autograft specifically. So, yeah,
that's awesome. Definitely check with the surgeon. But if no preference, then that's a good study. Do it up.
Do it up, man. Hey, friend. If you're liking this content, I have something I think that you're really going to love, and that would be a master course on rotator cuff related pain and rotator cuff tears. Having the patient come through the door and you don't know how to treat their pathology, that stinks. You feel like a fraud, you're just making stuff up. It's not good stuff. It's also pretty dang tough staying on top of all the literature that's coming out all the time. Well, guess what? I have done this for you by making a master course on rotator cuff related pain. Well, what kind of stuff do you go over in this course? I've got an evidence-based guide. We go over diagnosis and special tests, my favorite beginner, intermediate, and advanced exercises, how to modify your patient's training in the gym so they can keep on working towards their goals and not hurt themselves more, my favorite evidence-based manual therapy techniques for these folks, case studies on how to treat non-op and post-op patients, as well as the exact rotator cuff related pain protocol that I give to my patients when they come to see me with this common issue. Now that sounds pretty good, Dan, but how much does this cost? How does $1 sound? Whoa, $1? That sounds crazy. Why is it so cheap? It's mostly because I don't know how to run a business, but I do know about the rotator cuff, and I'll teach you all about that. This all comes with a subscription to Fitness Pain for Insiders. It's $1 for a 1-week trial and $25 per month afterwards. However, you can cancel at any time. If you don't like it within the first 7 days, just tell me. I will cancel and refund for you. Plus, I have a lot of other really good courses in there as well. We have master courses for cervical radiculopathy, lumbar radicular pain, lateral ankle sprains, and what I'm working on next is, you guessed it, your favorite, shoulder instability. So click on that link in the description. It's $1. Go ahead and get started, and I'll see you on the inside.
Key number 5, we want to improve volitional quadriceps control. This ties into talking about reducing pain and inflammation, but we know the longer that lasts, it's hard to contract your quad. There's this phenomenon that everyone's talking about. We hear very often AMI, or arthrogenic muscle inhibition. And this is the idea that quad failure is not simply related to atrophy, but it's also related to neural inhibition. So there's something else going on. It's not just the muscle. There's something going on with the nervous system. What we see helpful for this is that modalities which target different neural pathways to reduce quad inhibition, those are the things that have been studied. And they're mostly looking at motor recruitment via this reflex called the H reflex, and max voluntary contraction as outcomes. So when they do different interventions, are these things improving? There's a whole lot to this, and there's some good studies out there. And I know Dan had said he's going to do some videos showing how to work on these things. But these are
now.
Can't wait. These are
Watch
things
the rest of this video and then immediately watch those.
That's right. Just stay on fitness pain free all day. But these are things we're seeing in the research and something we have to pay attention to, and we want to improve this quad control. So special consideration, I thought this was pretty cool. So the two most proven ways to reduce AMI that I've seen in the research I was looking at is exercise, which I never thought of as a way to reduce arthrogenic muscle inhibition, but it's a very reliable way to do that. And we're already doing that in PT, which is awesome. And the other thing is cryotherapy. That's something that we know the research is showing with very strong evidence that it's worth doing. So all types of exercise seems to reduce AMI, open chain, closed chain, you could do anything. Okay. One of the things that was interesting is that hamstring exercises particularly seem to be helpful at reducing AMI. And the theory is that for some of these folks with quad inhibition is that there's a strong co-contraction of the hamstring and the quad, and that's not allowing the quad to fire properly. So if you do some exercises that over fatigue the hamstring, it's improving quad control and volitional quad control. So, if you have someone who's really struggling, try to smoke their hamstring and see if their quad's moving a little bit better after that. And that is pretty interesting. And this study found that to be a reliable way. The other thing is icing. So one summary statement from the study that I included here is that all included studies showed an improvement in quad strength and or the H reflex through the use of cryotherapy. And what I tended to see for a time required to do this is about 20 minutes. So, an idea that I've had some of my patients do, that if they have ice at home on their drive to physical therapy, they'll ice their knee. And then when they come in, they've already iced for that, say they have a 20-minute commute. That's awesome. Now they've gotten that out of the way and we can kind of get right to work in PT. The other thing is you could recommend they do this at home before they do their exercises. There's a window of time where their quad inhibition is decreased, and doing it pre-op or before exercises, pre-exercise can be really helpful. So definitely something I think we should start doing. There's like almost no barrier to entry with that, and it could be pretty helpful. So these authors looked at a ton of different things to reduce AMI, and the modalities which they deemed they can't recommend at this time due to either lack of evidence or lack of high quality evidence. They said TENS and NMES, they provide a small benefit, but at this point it's clinically insignificant. So they can't recommend that we prioritize those things. Vibration therapy and ultrasound, they deem to be questionable at best at this time. So, we could be on the lookout for more evidence for that. But the big things that they said we should be doing, no brainers, are exercise and cryotherapy. So I'd say be sure to include those. But if you want to work on some of the other things, if you have the time, perhaps it's worth trying. But their recommendation is stay away from other things, focus on exercise and cryotherapy.
Yeah, for sure. I did do basically another video showing a lot of these things. So cryotherapy, like TENS, how we like to set up things like NMES, biofeedback, vibrations with a power plate, which unless you have one of those in your clinic, you might not be able to do. Blood flow restriction training is kind of another one, although that's not necessarily just AMI. But yeah, exercise seems to be the big one. But if you guys want to see how we set up some of these modalities or cryotherapy, all those other strategies, and link in the show notes.
Key number 6, during the rehab process, we want to progressively load, and especially the quad. The quad is kind of the key here. Athletes who return to sport with weaker quads have a higher risk of re-tearing and worse knee function 1 year later. So you see a lot of high quality studies showing this, that getting your quad strength to at least 90% of the unoperative side is so important for reducing risk of re-tear. Open kinetic chain knee extension, as Dan was alluding to, is safe. It's a safe and effective way to strengthen the quads. And we can begin this as soon as possible. So that study by Lynn Snyder-Mackler, she really spent a good portion of the article talking about this and just linking some common activities with their peak strain on the ACL so we can understand why this is safe. So open kinetic chain knee extension, puts about 4 to 5% peak strain on the ACL. That's very similar to squatting, which we all feel pretty comfortable doing early on after surgery. And that's a lot less than the mid stance or the late swing phase of gait, which puts 13% peak strain through the ACL. So if we're okay with our patients walking after surgery 2 weeks out, or 10 days out, we should be okay with doing open kinetic chain knee extension as well. And then something that I always think is interesting is in surgery, after you're on the operating table, they've just reconstructed your ACL, surgeons will do a Lockman test. They'll do an anterior drawer test and a pivot shift test, and they'll stress your ACL on the table. And that puts about 4% peak strain through the ACL. So if we're okay doing these tests to test for laxity, we should be okay doing open kinetic chain knee extension. And we know that doing that will get your quad strength back earlier. And it's a very effective way to get back your quad strength. So don't be afraid of doing that. I would say I'm at the point now where I'm pretty much doing that as soon as the patient can tolerate it, oftentimes within the first 2 to 4 weeks. So, feel free to start working on that. I don't think it's a problem. And most of the surgeons we work with don't think it's a problem either. If your surgeon does have particular guidelines against this, I think you got to proceed with caution, but don't be afraid to. It seems like from a force standpoint, it's perfectly safe.
Mm. Yeah, it's pretty funny. I guess a few things about the open chain argument, walking's more strain than just doing an open chain knee extension. So if you're comfortable with your patient walking and they're taking lots and lots of steps throughout the course of the day, might as well do knee extensions, right? The other thing I like to think about is that your ACL is like at its strongest point right after surgery. So right after that surgery, the ACL is probably stronger than it is somewhere between 8 and 10 weeks, whatever it is. So if you're delaying until 8 weeks, which we have research to show it's safe at that point, it's like you're starting maybe at the weakest point there, right? Just kind of interesting. And last one that I always makes me laugh is like when you do a straight leg raise with a patient after that ACL reconstruction, what's the first thing that happens? The knee bends. It's like you're at almost terminal knee extension right there. So like a straight leg raise, which everyone prescribes, like why is that okay? Like that's okay, even though the knee is like really close or at terminal knee extension with that quad leg. But like an open chain knee extension, well, be careful when you get towards terminal knee. It's like, well, the exercise right before, we were there the entire time. Why is that one safe? So it's just kind of interesting. It does seem like a lot of folks are being more and more vocal that maybe we should be okay with open chain. I know Kevin Wilk actually is a little less okay with open kinetic chain knee extensions early on with rehab. And to be honest, like if you can do kind of partial range early on the first 4 weeks, like we see decent results potentially staying away from it early on too. So if the surgeon hates it, it's not like it's the end of the world. But if you are able to do it early on, probably better to do it, and if they're having a lot of trouble, you can always back off, use more BFR, whatever it is, reduce those loads, so on and so forth. You may be getting to this, but I know Delaware has a good protocol, and they show you how they do open kinetic chain early on, which may be useful for folks to see if you're not going to mention already in the future of this podcast, Kevin.
Yeah, they have a great protocol in general, so I think it's worth checking out, kind of based on all this research. But key number 7 here is don't neglect other types of training. So obviously strengthening is so important. We have to load the quad, we have to load the hamstring. Strength is a huge focus, but we can't just strengthen. We have to do other things as well. Perturbation training has been shown to reduce knee stiffness with walking and more effectively normalizes gait than strengthening alone. So a good indication for adding that. Training this early, pre-op and post-op, can have positive implications 6 months post-op for gait quality. So keep that in mind. Another hot one right now that you see a lot is neurocognitive training. And this is the general idea that sports are more complex than a single instruction task that we often do in rehab. So when you're having somebody do balance, that doesn't do a great job replicating the demands of sport. We know that there's a lot going on a field. You're paying attention to the defender, you're paying attention to the net or the basket or something, right? There's the ball, there's a lot going on. And we want to try to start working on that in rehab, because that's going to be a big challenge that these people face. Research has shown that deficits or delays in sensory or attentional processing may contribute to inability to correct errors in a complex coordination task, which leads to higher rates of re-injury. So if you have a deficit with this, it could lead to higher rate of re-injury. And then they also have shown that athletes with lower baseline levels of neurocognitive performance demonstrate worse landing mechanics than those with better baselines of neurocognitive performance. So, exactly by what mechanism this is happening, I think we're still learning, but we know that this is an important indicator of someone's risk of re-tear or how they're going to perform when they get back on the field as well. So we want to start implementing this in physical therapy. So we could use these findings to implement tasks that improve processing speed, dual task training, and multitask training. And there are so many ways to start incorporating this. I think even early on, there was a recent paper that I think Kevin Wilk actually published that was in IJSPT about neurocognitive training for ACL, and a lot of cool examples of how to progress exercises with that. I believe that's in our references for this one, so that's worth checking out. And they did a 2-part on that. So there's part 1 and then part 2 is coming out. But a lot of that is just, even early on, someone's doing something as basic as straight leg raises. As they're doing that, you can give them basic math problems to solve, or they only lift their leg when you say an odd number or something like that. This is infinitely creative. You could get infinitely creative with this. And I know there are good people online putting out stuff like this. And I'm sure Dan will be putting out a lot of stuff on neurocognitive training. But we're seeing more and more of this, and don't neglect this. Don't think we can only strengthen the quads and have success. We have to incorporate all these other things as well.
Yeah. Good stuff, Kevin. So a couple things. So, hey, I'm actually planning on making a video using that study with Kevin Wilk. They kind of have like a stage 1, stage 2. What was interesting about that study, just kind of reading over it briefly, is that they recommend a lot of neurocog early in rehab. And I tend to do more later in rehab. You know what I mean? A few thoughts. I think I'm going to put out a video so you can see some of the stuff that we like to use. I'm kind of guilty. I should probably use it more than I typically do. Right. One thing that I hope people aren't doing, I don't think folks are doing this, but neurocog is not just advanced rehab, right? I don't want folks to think that like, okay, to get to the advanced stages of rehab, now I add blaze pods and this is advanced. You still need to work on strength. You still need to work on power. So we want to make sure we restore the ability to sprint, for example, right? And do agility drills well first. And if that looks good, then yeah, go ahead and throw some blaze pods or whatever in the mix. But if your main goal behind your exercise is either building strength or building power, we still make sure we check those boxes. It's just the neurocog is an additional element that you put in. At least in my mind, it goes towards the advanced stages of rehab, just because when you're trying to build, let's say, strength, you probably need to focus on the set of the exercise you're doing over hitting a blaze pod while you're doing sets of 10 or doing math, because that's going to probably make you a little less strong, which is the opposite of what we want to try to accomplish. So neurocog is good. Just don't go overboard. Make sure you're working on all those other important sport qualities that the athlete needs to.
It's such a good point, right? Like we know the principles of training, right? You have to maybe single focus on a task first and then start doing some other things. But there are probably ways we can sneak it in early as well. But you're right.
I agree. It's like some people, like you've seen it in PT, like we're getting more advanced. All right, we go from squatting to Bozu squatting. Like, whoa, you're going the wrong direction here. You know what I mean? Then you're doing like a squat with a press overhead, and that's supposed to be advanced. It's like, well, you're limiting your legs by working the shoulder. Like that's not advanced necessarily. So it just makes sure that people kind of understand that. I mean, just the fact that you incorporate neurocog into your PT probably means that you're ahead of the curve. You know what I mean? From a physical therapy standpoint, but you just want to make sure that, you get a lot of new grads probably that are excited about this, and hopefully they're not like overdoing it, whatever. So
last thing I'll say on it is, we have an epidemic of returning to sport potentially without hitting the criteria of strengthening. So we have to do those basic things really well first. If your person's strong enough, but they need to get the fine details of neurocognitive training in their rehab, that's awesome. But like you said, you can't prioritize this over other things when you still have a 70% symmetry, right? That has to get better. So yeah, all good stuff. Key number 8, progressed by tissue healing timelines and objective outcome measures. So there's a combination of things, right? We can't just say, I think some surgeons I see go based on just time, and they tell the patient that you could start running. It's 4 months. You had your 4-month follow-up. Here's a return to run protocol. Or, you're at month 9, start returning to sport. Or even if you're at month 6, start returning to sport. You hear kind of arbitrary recommendations based on time. And we have to consider criteria. But at the same time, if someone's smashing criteria early on, we have to consider time. We can't just say you're hitting your return to sport marks at, 7 months, return to sport, because we have good studies showing that for every month you delay return to sport up to month 9, you reduce your risk by about 50% of re-tearing. So both are important. We have to consider both. It's important to educate your patient about both. So just some basic examples here, but the principle is to consider both. Something like plyometrics, I think you'll see in the research, a timeline-based recommendation is about 3 months. For criteria, we want to say about 70% or greater limb symmetry index. So take a little bit of both and see if you can kind of match those. That's what I use with my patients as a goal. By 3 months, can we be around 70% LSI? Can we be about 3 months out? And now we'll start our plyometric training. Similarly, for return to running, did they tolerate a good plyometric program in month 3 to month 4? Did the LSI improve? Are we close to 80%? Are they about 4 months out? Let's start running. Same thing with return to sport, right? I kind of will give a summary of recommendations, but I'm hoping we're waiting till at least month 9, hopefully a little bit longer, but at least month 9. That's some of our time-based criteria. But then when are they hitting these criteria-based progressions of LSI greater than or equal to 90%, greater than or equal to 90% for high performance testing, which we'll talk about. But blending these two is important. And it's important for the patient to know that you're going off both. So they don't think, hey, it's 4 months. Why am I not running yet? Well, you've already talked about this with the patient. You're not running yet because we only have 65% quad symmetry. And we know that if we start running, you're probably going to get swollen and it's going to be kind of painful. So let's just be smart about this and think about both things in our decision making.
Yeah, for sure. I like that, Kevin. I think it's super important. I like the idea of trying to say, we don't start plyos until we see this number, right? And then we can start progressing to more running when we get to this number. And then I've even seen, let's say, 90% for when you start doing, let's say, drills in practice, and 100% when you actually fully return to sport. So I've seen it kind of every percentage up by 10% is when you can incorporate more and more and more, which makes sense to me. I kind of like that idea. And to your earlier point, I had just a story, and we talked about the same athlete in the last podcast episode, but it was in an athlete who had a cadaver graft years ago, and he was trying to return back to hockey. And his doctor was okay returning at 5 months. And what I found with him, and I've seen with a lot of others, is like they may crush every single test. So his limb symmetry index was great. All his hop tests looked beautiful. Like he looked ready to go. And he went back and he retore. And he did that twice. And both times during that rehab, he looked amazing, right? So you'll see that. But I think on the flip side, you see a lot of athletes that don't hit these numbers, the 9-month mark. I think we were talking about that Bear study in the last podcast. Essentially, it was like 70-75% of folks had adequate symmetry to return at the 1-year mark. And they were closer to the 2-year mark when they actually hit those numbers. So I think what happens as physical therapists, you get frustrated pretty frequently. And you're just crossing your fingers that the handheld dynamometer test, whatever, look good. And oftentimes they don't. And sometimes you have to have a tough conversation. I think you had the same thing with one of your patients recently, and you may actually disagree with what the surgeon has to say. You're at 9 months or 6 months, whatever it is, and that limb symmetry index doesn't look good. And you're telling your patient, like, I know you're 9 months and the doctor says it's okay to return at this point, but you're still at a higher risk, and that stinks, right? Because that may delay all the plans that the athlete has. But unfortunately, I think it happens a lot. Like, I feel like I have this conversation way more often than I like to. And I have to kind of say to the patient, like, yeah, you're at an increased risk, and at this point, I let the patient make their own decision. Like, if they really, really want to return back to sport, like, I'm okay with it. Just that your risk is probably higher than someone who's, at 90+%, right? So I don't know if you have any thoughts on that, Kevin.
Yeah, definitely. definitely something we deal with. And the case I have right now is actually, so she's passed the doctor's return to sport tests, which I don't know how well implemented they were because I've done the same tests and she has not passed them. But she's also 6 months, a little over 6 months out, and she was told by the surgeon before surgery that he lets his athletes get back at 6 months. So this is where I have had a lot of conversation with her and with her family, just trying to give them the evidence that we're talking about today and some of the best research out there showing that delaying return to sport to at least 9 months reduces risk of re-tear. And then it's, they need to weigh what the surgeon tells them versus the best available evidence I can give them and, my clinical experience and my rationale. So that's challenging. That's definitely a hard thing that I think it's not uncommon that, especially in ACL, for whatever reason, there are definitely surgeons out there that, whether they think their techniques are better than what you see in the research, or they're just so busy that they're unaware of the research. It's hard to know why they say these things sometimes, but I think we've talked about this in this series of podcasts, is that at least ACL is, the good thing is there's so much evidence out there that, we're not completely guessing. We have good evidence to show that if we wait till 9+ months and if we hit these return to sport criteria, we're reducing our risk of re-tearing or tearing the other side as much as possible. And again, like you said, I'll let the patient make the decision and the family make the decision, but we have to educate them on these things. And it's challenging because you feel like the bad guy and people get upset, but you're trying your best and you're just trying to give them the right information. So
Yeah, I can see why surgeons are pressured to return back at 6 months, because the patient obviously wants to get back and they're getting surgery to get back. And if the surgeon says, "Oh, I let you go at 6 months," I find that my patients do okay with that. That's what the patient wants to hear. No one wants to hear it takes 9 months to a year to get back to your sport. That sounds horrible. So I can see why a surgeon might say that. Again, like, I don't have all the information as to why they're making that decision, but as physical therapists, we know that's probably going to increase your risk. So I just want to make sure we educate the patients. Sometimes it creates turmoil, right? You might have a surgeon stop recommending patients to you for that reason. Just make sure you know that may happen. But at the end of the day, I think you're doing the right thing, right? I think it's your evidence-based. A little bit of feedback to the patient is probably more accurate than what the doctor is saying. So it is what it is. I think we deal with it more often than we'd like to as physical therapists.
All right. Key number 9 here is give consideration to psychological readiness. So we're so focused as physical therapists on the physical side, as we should be. That's our role. But understand that this is a huge psychological burden on the patient. And there's more and more research coming out that this stuff is very important to consider, and that there are a lot of good referral sources out there. So a 2015 study showed that psychological traits such as self-confidence, optimism, and motivation are key factors to return to sport after ACL. And there's a lot of readiness kind of questionnaires we can give people. So utilization of an ACL RSI. And on this particular readiness index, athletes scoring greater than 60% after 6 months were highly likely to return to sport by 12 months. Conversely, athletes scoring less than 39% after 6 months were highly unlikely to return to sport by 12 months. So, I feel like athletes subconsciously or consciously have some indication of how confident they feel throughout this process, what their confidence is like, how optimistic they are, how motivated they are. That stuff matters. And we're seeing it pan out a little bit with some of these outcome measures. And in the area that we work, I think I'm seeing more and more of this for different types of surgeries. We do work with kids who I feel like are a little bit privileged. They have access to a lot of good things just being in the Boston area, and stuff like that. So sports psychologists are playing a huge role. I think I see a lot of high level athletes who are in high school and they're committed to play Division I college sports, and they're just a ball of stress all the time. And whether it's ACL or some other injury that they're recovering from, more and more often that they're getting good referrals to sports psychologists. So that's something to consider, is that this is outside of our scope and how we treat this, but it's our job to kind of pick up on this and make sure we're including some of these questionnaires for our athletes throughout the rehab process. So we know this is someone who we might need to refer out. But I almost feel like it's becoming a standard of care for these kids, is that if they go to a particular surgeon, they're saying, all right, here's our list of recommendations for physical therapy. You can go check out these places. Here's our list of recommendations for a psychologist or a sports psychologist. Go check these out as well. And I think that's awesome. That's fantastic, because it's not just fear of getting back to sport. It's a lot of times these kids are dealing with depression or anxiety around the fact that their friends are doing all these things they can't do. And these are huge considerations. So just be on the lookout for that, and give that some consideration, and try to establish relationships with a good sports psychologist in the area, so they can start helping your patients out as well.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms, or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is, if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door, so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. I like Kevin. Good stuff. Couple things. I think that just to touch on the psychological readiness, there are a few questionnaires, and there's a lot of them out there. Maybe I'll include a couple in the show notes. Some papers will even recommend your return to play. So basically getting back to running, and then getting back to higher level plyometrics, and then getting back to, let's say, practice, but at a lower level doing drills, and then getting back to scrimmaging, and then getting back to like full playing, based on psychological readiness. So kind of like your limb symmetry index, you start at a certain point. As you get your limb symmetry index up, then you start doing more. You can do the same thing with psychological readiness, right? And to kind of touch on your early point about athletes being stressed out, we know they are. They have kind of unique demands. A lot of these folks are school demands, right? Stress with like finals. We have clear research, very interesting, that injuries go up around exam times. Stress levels go up around exam times. And the amount of stress that these athletes perceive directly correlates with the amount of injuries they have too. And one of the things I find interesting is that if you employ a stress management strategy for these athletes, it reduces injury risk. So just by addressing some of that mental strain that's going on for those athletes, it helps them out, right? So if our goal is to reduce injury risk as much as possible, which like we go crazy with that sometimes, right? We're hop testing, psychological readiness, range of motion, all this stuff. You might be ignoring that psychological side. And if you refer to a sports psychologist, and I would recommend a sports psychologist if you can, just because other psychologists may not have the expertise that the athlete needs. They're not used to doing that. You can actually reduce that injury risk. And that's just by trying to intervene from a psychological standpoint, which is really cool. So I just think this is really important. And those are a few easy things you can do, just like Kevin said. So
that's interesting. I wasn't aware of the injury risk, but that makes total sense. And the rates going up during times of finals, and it makes sense. They're more stressed. They're not sleeping as much. They get crazy, which makes sense. I remember horror memories.
Yeah. One of the things and this is one of the things I teach my course and stuff, is that I'm blanking on the name of the author. There's a couple like papers that I mention all the time, but one of the things that was really cool is that in the study, they used some more advanced technology to try to figure out people's stress levels, right? But they also use a really simple score of like a 0 to 3 of how stressed people felt. And they had called like a mood score on the scale of like 0 to 3. And if you're on the higher end of stress, that correlate with more injury. And if you're on the lower end, there's less injury. So a few things, you can use that number and just see if it's high all the time. Like that's probably not a good thing, right? You probably want to try to figure out how you can lower that. But the second piece is that it can potentially dictate what you do with your training. So if you have a high stress day, or you've been having a lot of stress with studying for finals or whatever else is going on, high levels of perceived stress, probably dictates what you do from a training perspective or game perspective as well. Because you might be going into a high risk environment, super stressed out, go play a sport at a high level, you might be more at risk, right? And I don't know if we know that when your stress levels are high, then you're more likely to get hurt. And if you don't exercise that day, you probably remove that risk, or if you like reduce the stress. But I don't have the research to show that's necessarily true. I just think that logically makes a lot of sense. And that's one of the things I advise to my clients and patients, because it's super simple and makes a ton of sense from a logical standpoint. You know what I
mean? Key number 10, implement return to sport testing. So when we're at the phase of should we get back, should we not get back, we're considering the timeline, tissue healing timelines, but we're also considering this criteria of returning to sport. Kind of three factors to consider is biological healing, physical readiness, and psychological readiness. So in terms of biological healing, studies on neoligamentization, I think I said that all right, show that it takes upwards of 2 years for the ACL graft to fully mature. And I know Dan said on a previous episode, sometimes we see as high as like 4 years it can take. So how long does it take this thing to fully incorporate? Should we wait 2 years to return to sport? Maybe you could argue that from a biological standpoint, but I don't know if there's a big difference in re-tears between years 2 to years 4. I know most re-tears occur in the first 2 years. And the other thing is that, coaches, athletes, they're just not going to stand for that. So at some point you say it's worth the risk, right? You're deciding that you reduce risk to a certain point, let's return to sport. But, something to consider is it does take a long time for the graft to fully mature. The University of Delaware showed a 51% reduction in re-tear for every month return to sport is delayed up until 9 months. So that's a crazy huge statistic. If you say the average return to sport rate, tear rate when returning to sport is something like 10 to 20%. And as you had said, depending on the sport and the study, you see really high, sometimes 25 plus, 30, 40%. Well, we can reduce that risk by 51% every month we wait up until 9 months. So after 9 months, it doesn't seem to be a huge reduction, but that's kind of where my recommendation, which we'll have here in a minute, is that I think we should wait at least 9 months. That's kind of, if we can, that's my recommendation from a timeline standpoint. And then we wait for the other criteria, but that's a huge statistic that I think is really important to keep in mind. And then other studies have shown a 7 times reduction in re-tear rates when waiting at least 9 months until return to sport. So there does seem to be something magical about that 9-month mark. we're reducing risk a pretty fair amount. And I think it's something we should all consider. For physical readiness, there are valid tests that we want to use. So quadriceps strength asymmetry, it's a major risk factor for re-tearing. One of the studies by the University of Delaware, I think it's titled a reduction of 51% for every, simple decision-making rules can reduce re-tear rate. It's in the study show notes. It's one of these references here on the slide. But what they showed is that of all the factors important for returning to sport, quad strength is the most important one. When you isolate all the other ones, if they're not hitting a quad symmetry of at least 90%, that's the biggest risk factor for potentially re-tearing or injuring the other side. So all of the return to sport tests are important, but that's probably the most important one right now, according to the research. And then just in terms of the gold standard, what could we best use to test? The best thing is isokinetic testing. That seems to be the one that we're comparing against. I've never used one. We don't have one at Champion, but a lot of surgeons' offices have one. And I think if you have access to one in your area, it's worth doing. The authors have said that handheld dynamometry with fixation, with external fixation, is a valid way to test quad strength. So definitely, if you have one of those, that's a little more affordable and more easy to get in the clinic. It's a valid way when compared to isokinetic testing. We don't have to feel bad using that. It has good evidence to support it. So you should use that if you can. They also have there is validity for 1 rep max testing on a knee extension machine. And there's validity from testing from 90 to 45 degrees and 90 to 0 degrees. So if all you have is a knee extension machine, you can also feel relatively comfortable using that. But that goes in order, I think, of the best evidence to the worst. So isokinetic testing would be 1, handheld dynamometer with external fixation would be 2, and then 1 rep max knee extension from 90 to 45 or 90 to 0 would both be acceptable. They caution against using a 1 rep max test for a leg press and single leg squatting. They kind of say that there's too many ways you can compensate, and those tests do not seem to be accurate compared to an isokinetic test. So one of these 3 methods is okay. Hop testing, there's a good study that showed a 75% lower risk of re-injury for patients who pass the hop test versus those who don't. And I know that this has been a little bit controversial because there was another study that came out showing that there's a higher risk of re-tearing if you do pass the tests. But there was a follow-up study showing that the methods used in that study weren't phenomenal. So I think it's interesting for people to go back and look at these, and they're all linked here as references in the title of this slide. But go back and look at them yourself, because I think it's important to see that a lot of the times we look at studies and we look at the headline and we take that information and run with it. But when other people go in and look at the methods, they see a lot of times they're combining things that shouldn't be combined, and they're combining cohorts and groups that shouldn't be combined. So, important to consider. But as far as I've come across in this review, hop testing is still a valid way and can predict lower risk of re-injury, and something we should be using. And I think the quality is important to consider as well. So not just what is the objective number showing us with these tests, but how do they look doing it? Is there a huge compensation strategy? Are they a little bit fear avoidant? Definitely important to consider. It's more than just the numbers, but we should be using these. I do think there will be probably some transition to force plate testing as we get more and more comfortable using force plates. Maybe that will overtake these, but I think for now, these are still pretty valid. So the standard 4 that you see often, a single leg hop for distance, a 6-meter timed hop test, a triple hop for distance, and the triple crossover hop for distance. So there are a lot of places you can look for the reliable way to implement those, but those are the 4 that we're using. And then in terms of psychological readiness, Dan had said, and definitely true, there's a lot of different outcome measures we could use for this. The ACL-RSI, ACL return to sport after injury, is a validated self-reporting tool. So kind of combining all these things is what we consider return to sport testing. consider all three of the biological, physical, and psychological readiness.
I like it, Kevin. Just one thing to add is that I'm going to be doing a video on return to sport testing too, and I'll cover all the hop tests and also cover how we like to do the handheld dynamometry, isometric testing, measuring things like torque, so on and so forth, just so people have an understanding of how that kind of goes, and they can see it in action and not just like the theory of it as well. So
can't wait. Can't wait. Here's a little chart. Actually, do you want to expand this fully? Yeah, that's better. This is just from one of the articles there linked in the top, and it's summarizing the clinical recommendations for return to sport. So if they gave it an A, this is a SORT evidence rating is what it's called. If they give it an A, it's consistent, good quality, patient-oriented evidence. If they give it a B, it's inconsistent or limited quality patient-oriented evidence. If they give it a C, it's a consensus statement, a disease-oriented evidence, usual practice, expert opinion, or it's from a case series. So A is the best quality, then B, then C. So initiating pre-op rehab to restore quiet knee and achieve pre-op milestones gets B quality. Initiating quadriceps strengthening in open kinetic chain immediately post-op and utilizing reliable objective testing to monitor progress also gets a B. Utilizing both biological and criterion-based timelines to inform decision-making gets an A. Delaying return to sport after ACL reconstruction with a minimum of 9 months and allografts a minimum of 12 months, and after successful completion of return to sport battery gets an A. So I think that's amazing. That is where I feel like we can really have confidence saying we should be waiting at least 9 months. Utilizing both biological and criterion-based timelines to inform decision-making gets an A. The ACL RSI is a valid tool to monitor psychological preparedness after ACL reconstruction gets a B. Return to competition should be stepwise after restoration of pre-injury conditioning gets a C. So that's kind of saying that we don't just return to sport. You pass your test, go play in the game. Let's make this a stepwise return where maybe we're going to practice without contact and half the practices during the week. And then we're going to all the practices without contact. And then we're adding in, contact. So a little bit of a progression there. And then a secondary prevention program should be performed 2 times per week throughout the athletic career. And that's also with a B level evidence. So I think some good things there to consider, kind of see where these recommendations are coming from and how strong and confident we feel in them. But again, to reiterate, I love the A for waiting at least 9 months after completing the return to sport test battery. So that's pretty good.
Yeah, those are really good recommendations. And just so people understand, like the grading of C doesn't necessarily mean that it's wrong. It just means we don't have research. It's just consensus or expert opinion.
Mm-hmm.
I really like Kevin Wilk and his research because he talks very much about a stepwise progression back to sport. And I feel like that's very much lacking in most kind of rehab to return to sport protocols. And maybe research over the course of time will show that's not important. You can just run straight back. But in my mind, it makes no sense that it's not important, right? Despite it getting a grading of C. But really cool, what did get a grading of A, and that's probably something you really need to focus on as a physical therapist, making sure that you have nice criterion-based, stepwise progression back, hitting all those milestones seems to be really wise.
Mm-hmm.
The last thing I will say is that we didn't talk much about this, but I'm going to be doing a video about prevention programs after you've had like ACL reconstruction or prior, and you're trying to reduce your risk of having ACL injury. So you can see some of what these studies show to be beneficial for folks because they seem to be pretty dang helpful. And this is a total anecdote, but it's just been like my mantra. I've gotten a lot of injuries over the course of time, and I feel like half of my training sometimes is trying to prevent recurrences. I think my like calf strain is one of those. Like I'm just constantly doing so much calf stuff, but and I will find if I slack off sometimes. I know you hear this all the time. When patients tell me this, I'm like, yeah. But folks will say like, yeah, I've been doing my back exercises for 10 years. I stopped doing it. And lo and behold, my back started hurting. In my mind, I'm like, yeah, probably not. It's probably something else. But Anecdotally, more recently, if I drop off certain things, I notice those areas start getting sore again. So maybe that is the way we have to go with some athletes, just that, for the high risk ones, they're always doing some sort of prevention. For the folks that have a past history of these injuries, then yeah, they really do need to make sure they stay on top of these things. So we'll go over some of the research, and we'll talk about some practical strategies for you too.
Yeah, and I'll just say our boss Mike Ronald often talks about like the utility of those clinical commentaries. They're those level C evidence according to that level of grading, but it has so much utility and you learn a lot from it. But you just know that it's not the level A or B, and we want more of those. But it's okay to look at the level C. Doesn't mean it's not good quality. It just means that it's expert opinion, and you understand that, you take it with a grain of salt. But some people do this really, really well, and we want to do what they do because they've been doing it a long time and they've gained a lot of wisdom. So I love that kind of study.
Yeah.
Yeah. Key number 11, important here, I think, is collaborate with others to assist in return to sport decision making. This isn't just your guidelines and what you would like to do for return to sport. This is a huge decision that goes into the whole process here. So it's working with the athlete, it's working with the surgeon, you as a physical therapist, the family if it's a younger patient, sports psychologist if they're involved, the sporting schedule, the coaches. This is a huge kind of village that makes these decisions. Ultimately, it's up to the athlete and the person and their family, but everyone's playing a role here, and we're trying to all provide them with the best kind of advice we can give them. And they're using all of our advice and information to make a decision on when they feel safe to return to sport. So just understand this is a team thing, and this is kind of very true with ACL, but I think it's true for almost anything that we're treating. Is we're not the sole arbiter here and the one telling the patient what they need to do. Their whole life, it's a biopsychosocial thing, right? As we learn in school, and all of that is important. So there's a whole team that makes those decisions, and we're just a small part of it. But we like to work with everybody else, and I think we're getting better at that over time.
Good stuff, Kevin. I think that open lines of communication make the experience so much better for the patient. So essentially, if you can reach out to the surgeon if need be, if you can talk to the coaches or the trainers, right? You have everybody on board, helps so much. And I think it really makes the patient cared for, and it makes your rehab process a lot better. So if not already, try to form some active communication with the surgeons you're working with. And as you get towards the later stages of rehab, if you want to start talking to the coaches or the trainers, whoever they might be, that also really helps with that transition from PT over to return to sport. So super important. And then oftentimes, if you don't have good communication, that becomes messy, right? It becomes kind of a problem. You have contradictory opinions, and it just becomes kind of a pain. So yeah, communication is good.
All right. This is the one we've been waiting for all episode. I think the most important key for successful post-op rehab is to follow fitness pain-free. You want to subscribe, you want to rate and review. You want to share it with all of your classmates and friends, because then everybody does a better job treating ACLs. So I think that's the best part. I think with this whole podcast episode here, I could have gone into like very detailed, like here's what you do phase 1, here's what you do phase 2. I know you're going to go over a lot of great videos with exercises, like you had said, and return to sport testing videos and neurocognitive videos and all that good stuff. I thought this kind of overview approach would be a little more helpful for people. And so I hope these were helpful, and you can really kind of help guide your return to sport and your whole post-op rehab decision-making with some of these principles. And check out some of those papers too, because I think they help. They get into a lot of detail that I didn't put on here because it would be a 7-hour episode. So check those out and follow Fitness Pain Free.
Yeah, man. Good stuff. Yeah, I agree with you. There's so much to cover. It'd be absolutely ridiculous. You know what I mean? I like the style that you had, and then any holes that we have in terms of, because I'm going to have videos for plyometric progressions, return to sprinting, agility, all my favorite knee exercise to rehab folks, return to sport testing, right? Everything is going to be covered. So you'll have a comprehensive idea of how to do this. And then I actually have a case study on my Fitness Pain Free YouTube channel for post-op ACL. And then my future NEAT courses, as well as insiders, I'll have protocols in there too, as well as additional case studies. So if you want to see exactly how we do it, you can see that as well. So, but yeah, good stuff, Kevin. This was a fun one today. All right, guys. So now you're experts with your ACL reconstruction rehabilitation, but there are still some important nuances that you have to understand from a graft type when you're rehabbing your patients with an ACL reconstruction. And I've got a video for you. I'm going to put it right over Kevin's head there. We go over the best surgeries for ACL tears, where we go over those specific graft types, and give you some good little tidbits and advice for your patients with different grafts after ACL reconstruction. Go in the video, and I'll see you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain-Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I add to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.